Hello, welcome to this week's question and answer session. I'm Dr. John Kruse, and for the next hour, I'll be available to answer questions about the videos I released just this past week or about other ADHD topics or mental health topics in general. I'll summarize those two videos. As a disclaimer, as always, the information here is provided as information. It's not specific recommendations for anyone's treatment. So please take this information to your healthcare team, and hopefully it will inform your decision making. And it may also be a good idea to let your providers know about this channel, because there's many professionals who seem to have gotten good information from here. So the two topics this past week, two older videos that were sound corrected and released, were on Concerta, and the title originally was "What was the problem with Concerta?" The other one was on borderline personality disorder and ADHD. With Concerta, it was targeting that the reason for shortages of Concerta were somewhat different than the Adderall shortages. There was much more, I would say, corporate finagling. So for years, the maker of the generic version of Concerta was the exact same overarching company. It was a subsidiary, I want to say Pioneer, begins with a P. I'm forgetting the brand they used, but they were made exactly by the same company, the same facilities. There were corporate different levels. And the decision was just made that they weren't going to be making the generic anymore. They knew that that would reduce their sales, but since they were charging 10 times as much for the brand name as for the generic, again, exact same product made in the same facilities, that caused severe shortages. The other aspect is that the brand name Concerta is the only methylphenidate product that uses an osmotic delivery system to slowly pump out the drug at a steady rate. Strangely, the generic versions of that drug do not need to have the same mechanism of action for release. Some of them were osmotic formulations. Some of them were just simple, locked in a different matrix that dissolves slowly. And many of those other generic versions of Concerta were found to be not bioequivalent. So the same drug was in it, the same general rate of release, same general peak levels, but the variance was different enough from the brand name that the FDA did declare these were not equivalent products. Gina Pera, the blogger and the writer of Is It You, Me, or Adult ADHD, has written extensively on this, so her blog is a good source for more information there. The second topic was borderline personality disorder and ADHD. And on the surface, they seem completely different entities, but there's a huge amount of overlap. And I'd say the two areas clinically I see most problems is that there are many women with hyperactive aspects of ADHD, where for years, girls didn't have ADHD. And then when they did have it, they were only allowed to have inattentive type. I'm being a little flippant here. So anyone who is behaving in a volatile manner, many clinicians would think borderline personality before they would even think of ADHD. So that's one potential area of overlap and confusion. And I think it goes the other way as well, that since borderline personality disorder has historically been so closely linked to women, men with valid symptoms that seem to cover the diagnostic aspects of borderline personality disorder are often just considered, oh, they're just ADHD, and that's why they're acting in this way. So there are, I think, misdiagnoses both directions. You can certainly have both together. We can talk about that in more depth. And one other announcement, I sent out an email about, I will 2 weeks from now be a presenter in the ADHD Entrepreneur Summit. I don't get any commission or anything from them. I don't know how valid or useful it is. I know I was interviewed for an hour, and the interviewer was thoughtful and considerate. My topic is going to be on making friends with schedules when you have ADHD. So that's going to be, it's online, it's in 2 weeks. And also a shout out to the Reddit subreddit thread, so that may be a better place for discussions and questions and answers on themes here. Are 2 other comments. I inadvertently deleted the borderline personality ADHD video yesterday. It is being restored if it hasn't been already. That was my error. There were lots of good comments there that are irretrievably lost. I'm sorry about that. And without further ado, I do see there's at least one question sitting there. Patriot. So thanks, Max. So the company, so it's a branch of Johnson & Johnson, and there's another layer or 2 of corporate, but Patriot was the brand named generic version of Concerta, which again was being made in the same facilities and is identical to the generic, or the brand name in the generic, that version of it. Hello, hopefully I am back again. Thanks for your patience. So I am, as I wrote in the chat, I am completely dependent on Elon Musk's Starlink. I'm in rural Hawaii. That haven't been major problems until recently. So I'm not sure where I got cut off in the answer to Dennis's question. I was talking about borderline personality disorder and ADHD, and his question was, how do people with borderline perceive the behavior of others? So if I'm repeating myself, someone stop me if you didn't hear this. So one DBT, dialectical behavioral therapy, developed by Marsha Linehan, is one of the most tested and effective approaches for reducing a borderline symptomatology, particularly suicidal actions and behaviors. And an essential part of that framework is teaching people in a group format. So I think that format emphasizes or tries to elicit empathy and understanding, and trying to help those with borderline personality disorder understand why others are behaving the way they do and what their own behavior may look like to the others from the outside. And it's confronting, I think, a fundamental barrier, difficulty, challenge with those with borderline personality disorder, who tend to view most of the rest of the individuals in the world as attacking, undermining, distorting, manipulative. Some people they will over-idealize and see as perfectly good, but the basic stance, I'd say, towards everyone is the world is a scary, dangerous place. And I think a particular challenge is getting them to understand the behavior they just did, which they think is perfectly reasonable, logical, and warranted, may seem excessive and extreme to other people. And yet, again, when they view others behaving that way towards them, they get very defensive and attacking. So I hope that answers. Yeah, and so Max, the other thing that might have got lost, so Patriot was the brand name, so it was a branded generic. Patriot was the manufacturer. It's a subsidiary of Johnson & Johnson, and there's at least another layer of pharmaceutical company names and organizations, which I'm not keeping track of. But for Concerta, the same company was making the brand name product and making the number one branded generic. There were other generics, and they were making them in the same facility. So there's a question by G, I'm guessing on the Reddit, who questions, he sees a lot of commentary that people claim those with ADHD have a special advantage in sports, and he doesn't really see it or believe it. So what I would say to frame this starting out is, again, ADHD is fairly common. So at least 4% of adults have full-fledged ADHD. Probably at least as many more are on the substantial ADHD symptoms and on the spectrum. So you would expect random chance that a considerable portion of prominent athletes do have ADHD. And I think often people single out, Michael Phelps, the swimmer, or trying to remember which quarterback football stars of, it would date me, I think Terry Bradshaw, but I'm not sure. Others have come out as acknowledging their ADHD. And one quarterback out of dozens of NFL teams doesn't mean ADHD is overrepresented. So I'll start with the other side of the question. We do know that exercise, including vigorous exercise, does seem to have both immediate effects on improving executive functions. And there have even been studies of people on a treadmill looking at sort of very immediate reactions or improvement in executive functioning. There's also good evidence that more sustained, ongoing physical fitness is correlated with less severity or impairment from ADHD symptoms, excuse me. So there's a connection there. There's also the general description of ADHD that people with ADHD brains are interest-driven, others are importance-driven. So if you really enjoy your sport, that can help motivate you and keep you focused on practicing and perfecting your skills and techniques in what for someone else might be a boring bunch of drills and repetitive skill improvement. And particularly to the extent that someone might be able to learn how to hyperfocus or get better at hyperfocus, and the ADHD brains are more adept or more likely to hyperfocus to begin with, may be an asset. There's also clearly cases of athletes who were doping with stimulants, some who did seem to have ADHD, some who didn't have ADHD, and the Olympics and many other sports organizations have explicitly banned the use of stimulants for athletes who are competing. So I don't think there's any substantive survey looking at whether ADHD is overrepresented in, I'd say, professional sports individuals. Okay, so there is another question. I guess it got completely... It's not letting me scroll to the top. Oh, it says it's at the top of Mr. AK's. So thanks, Max. I'm not sure why I can't scroll back to the top. I can scroll up. But so Mr. AKA's question was whether the euphoric effects of stimulants seem to dissipate quickly after one dose for him. And the question is whether that's because the D2 receptors downregulate faster in the mesolimbic system compared to the D1 receptors in the prefrontal cortex. And I don't know of any rigorous research that's tried to demonstrate that that's what's going on, particularly in humans with ADHD. So there are 4 major dopaminergic circuitries in the brain. The mesolimbic system is the one centrally involved in emotions and reward. And it's certainly conceivable that that system would be designed to reset more quickly or adjust for experience, and that some of the mesocortical dopamine circuits to the frontal cortex may have evolutionarily be designed to be more stable over time to bursts of dopamine coming through. So it's certainly plausible. I just don't know if we have direct evidence that that's what's going on. So another Reddit question by Profit Tricky 4085. Do you have any thoughts, research on how dehydration can impact ADHD? They've noticed a huge difference in focus if I'm hydrated early versus late in the day. So I'm not aware of any research. There's a slightly overlapping. I do have a talk on temperature regulation, and clearly higher temperatures, particularly core temperatures, once your brain starts overheating, we know a lot of neurochemical actions and neurocellular functions become impaired with heat. It's certainly plausible that dehydration, if it's at a significant enough level, is also interfering with neurochemical and cellular functioning, but I'm not aware of much explicit research, and it would be tricky to get human subject review accepted for let's dehydrate people till their brains start dysfunctioning and see what's happening. Yeah, so medications that are particularly dependent on the kidneys for excretion certainly are affected strongly by dehydration, but in the mental health world, that's primarily lithium, which is used for bipolar disorder. The amphetamine, methylphenidate, and most of our non-stimulants are primarily excreted, metabolized by liver, not by kidney. So I would certainly support and recommend staying well hydrated. That's, again, good for optimal brain and body functioning. The other issue is whether it's really dehydration or other circadian differences or other factors of what's going on. If this individual noticed a huge difference if they're hydrated early or late in the day. So Max asks a good question, and I've talked about it or I've written about it. So in the borderline personality video, I mention higher rates of divorce and lower rates of marriage in examples of dissatisfaction in relationships. And is stability inherently a good thing, though? So part of the reason for citing those statistics is if you just say people with borderline personality or people with ADHD have more trouble in relationships, that sounds like such a one, pejorative, which it is, but two, subjective. How are you deciding? So looking at divorce statistics, looking at ever married statistics, looking at duration of marriages, looking at satisfaction with your friend group or romantic group are quasi quantitative ways to try to measure quality of relationship life. But I agree strongly with Max that particularly in American society, even as divorce rates for several decades now have hovered around 50%, we glorify and extol the Jimmy Carters of the world who were married for, I believe, 70 plus years. I think that's great and wonderful that they were happy with each other, but I don't think it should be held out as a model for everyone. And I'd say particularly with people with ADHD having a propensity for being bored readily unless your spouse is providing the variation and variability and other things you need. Why would one 50-year relationship be intrinsically any better than 5 10-year relationships or 10 5-year relationships? You could argue that you're actually getting to explore a broader depth or at least broader breadth of humanity. You're interacting with more people. You're contributing to more networks and communication systems. You are enriching yourself and those people more than just by going deeper in one relationship. I do, as a parent and someone who had to struggle to become a parent as a gay man growing up in the 60s. I do think there is some social value or child rearing value to having some primary long-term relationships between adults as caretakers of children, but there are research on group approaches for that and kibbutz and other social situations where there may be more group. So I think the only value, well, that is the biggest value for or social potential advantage for a valuing one long-term relationship over multiple shorter relationships. But I'd say after the child is reared, so after 20 years, it might be great, it might be harmonious, it may be wonderful to have a happy family to go back to. But I think after a child has passed most of their growing and adaptive milestones, they will be able to adjust if parents were to split up or develop additional relationships. That's a gross generalization. I'd say the other reason long-term relationships have been glorified is an overlap with sort of capitalistic and prior to that sort of feudal systems, that if you keep splitting up and you may potentially be fragmenting your fortune. Whether that's a bad thing or a good thing, I would argue that's probably a good thing in spreading the wealth, but that may be my politics. So I won't go further on that direction unless someone wants to. So Kalo Espindola says, does serotonin reduce the effects of stimulants or increases ADHD symptoms? Felt that my Vyvanse was not working much with 40-oxetine, 15 milligrams. So I do have some talks on combining medicines. I do have some talks on anxiety where I talk about serotonin drugs. So there's serotonin systems and norepinephrine systems do interact and modulate each other. I think that's actually a large part of why dual acting agents, so SNRIs like Cymbalta, Fatsima, Effexor, tend to be more tolerable than atomoxetine, a simple norepinephrine reuptake inhibitor. So there's interactions on lots of levels. It usually medications that are sedating, like benzodiazepines or barbiturates, are more commonly placed as being in opposition to stimulants. So I think one of the big intersectional areas is the realm or area of anxiety. And there are people with ADHD who use threats of deadlines or threats of really need to get this done now to motivate themselves to work. And certainly being on a medication like an SSRI that over time, over 2 or 3 or 4 weeks, reduces much of that can reduce or often reduces much of that anxiety. That certainly I've seen be counterproductive or help. Someone is less productive, less functional, less getting their tasks done because of their SSRI. Vortioxetine itself has weak SSRI action. It works on several other serotonin systems, including particularly serotonin 7 receptor, which is actually thought to have some pro-cognitive or executive function benefits. And there's been some research looking at it I don't know that any of this has been published actually for ADHD. Certainly for dementia, they're exploring it. So that, but each individual is allowed to respond in their own individual way. So yes, certainly it's fairly common for people to feel more placid, more content, and particularly if they are relied on their anxiety, which may have been coming from ADHD, to get things done, they may be more impaired on the combination. Max asks, how is psychoanalysis seen in modern psychiatry? It seems like many of its theories were more ideology than science and did more harm than good, especially in people's perception of mental health. I think that one, I can't give a global answer because I think mental health is a fairly fragmented field and people tend to like what they are doing or what they're interested in. And so, not even getting into biological psychiatry versus psychodynamics. One of my recent talks here was on trauma and PTSD and complex PTSD and ADHD. And many of the trauma people, even though I tried to separate or clarify, and it's absolutely, if the genetic evidence is, if the evidence, and it is compelling and extensive, is that genetics are a stronger contributor than the environment to whether someone develops ADHD, full-blown clinical ADHD, you can't argue that it's all trauma. That just doesn't hold water, and it doesn't hold water with looking at individuals' lives. But if you're in that mindset, that's what you see and believe, and you'll discredit ADHD and genetics and biology. So what I will say is I am surprised that some of the colleagues, psychiatrists that I trained with, who were among the most bright and curious in their thinking, a handful of them did go into psychoanalytic programs, which is a lot of time and effort beyond just psychiatry residency training. So these are individuals I respect. I don't think they're following a lot of the classic Freudian thoughts, but their framing is that child development and subconscious urges and the relationships and patterns of interactions with individuals you form early in life are essential and carry forward with you into the future. As during medical school years, the one quote I remember from the psychiatrist who taught many of our sessions was, his phrase was, "The past participates." I think that's a really good one. It doesn't dictate, it isn't determining everything everyone does, but it's there and participating. So one is, I think it depends on how loosely or tightly you define psychoanalysis versus psychodynamic. So maybe that's the best I can say. So Birdie Beagle asks, can Wellbutrin be taken as needed? So again, this is not a specific recommendation. This is not a telling you how to do it. This is information I have had. So if you're taking Wellbutrin for depression, all of our evidence with all of our, I'll say, historical antidepressants, so ketamine and maybe some of the newer things may be different, maybe Auvelity may be different that work faster, but all of our traditional antidepressants that clearly take weeks to develop their efficacy, even though they're having immediate biochemical effects, there is overwhelming evidence that one of the best predictors for poor results is not taking your medication consistently. And this fits with sort of the assembly line or industrial process model for how these are working, that these drugs are serving as a signal. They're telling the brain to change how nerve cells are talking to each other, change the proteins they're making, maybe make new nerve cells. Those are all processes that take a long time and a lot of effort, and the brain needs to get a pretty strong and regular signal. Keep doing this, keep doing this, keep doing this, to keep doing it. And if you are intermittent in your use of the medication early on, then you're going to be less likely to get that whole production line geared up and working. On the other hand, and we seldom advertise this fact, there's also extensive data. once an antidepressant of this old class, SSRIs, tricyclics, monoamine oxidase inhibitors, Wellbutrin, Surzone, other Remeron oddballs, once you're getting a good effect, there's also pretty substantial evidence that missing your drug a few days a week does not disrupt the antidepressant action. It can cause withdrawal syndromes depending on the drug. And that also fits with this assembly line model that once the assembly line is up and going, you don't need to send in a work order on Sundays. The line can keep going. It's going to sustain itself. So that's, if you're using Wellbutrin for depression, you should keep taking it fairly regularly. But if you miss it for a few days after the first few months, when you've established the assembly line working well, you can probably miss it occasionally. Again, you wouldn't be taking it as needed for mood because its mood effects are slow and indirect. So you shouldn't, if I'm feeling down, double up on the dose today. If I'm feeling okay, I can skip a day. I wouldn't use it that way. On the other hand, if you're using Wellbutrin for ADHD symptoms, all of the evidence I have is that it works immediately and directly and boosts norepinephrine and dopamine immediately. The clinical interactions I have with patients who say, I know the day I'm taking it, it's working. And there, in that scenario, if you're not taking it also for depression, then it is completely reasonable from my perspective to take it intermittently and on an as-needed basis. The other element to add into here with Wellbutrin is that unlike the SSRIs, where at least 40 to 50% of people have some withdrawal symptoms if they abruptly stop it, and I should clarify that despite some proponents screaming otherwise, and there have been some individuals with severe and miserable SSRI and other antidepressant withdrawal syndromes, far and away, the majority of people who have withdrawal symptoms from SSRIs, they are short-term and mild and self-limited. And even people with severe withdrawal symptoms, if you go back and taper over a long enough period, which is often several months, most of those people can successfully get off their medication. So in contrast to that, Wellbutrin does not have a consistent withdrawal syndrome identified with it. Far and away, I've had two people over a 30-plus year career who did feel they had substantial and immediate and significant withdrawal symptoms from Wellbutrin, but that is a much, much smaller minority than occurs with SSRI withdrawal. So usually Wellbutrin is, if you're taking it for ADHD, could be used on the days you need it and skip it on the days you don't. So Chad Austin asks, and it's a question that keeps coming up, but I'm happy to keep answering it if it's out there or trying to answer. If a patient doesn't want to take stimulants or medication in general, are supplements really going to have any efficacy? So when we look at effect sizes, and it's hard to do that unless studies are designed really equivalently, which they're usually not. I mean, clearly, amphetamine products help the biggest proportion of people with ADHD and help them to a greater extent. Other non-amphetamine products are in a smaller range of efficacy or lower range in terms of don't help as large a percentage of people, don't tend to help symptoms to as strong a degree. And I would say in general, supplements tend to be even the notch lower. That doesn't mean some individuals may derive all they need from those supplements. Some individuals, and we're talking here substances, and whether or not someone is using cognitive behavioral and other strategies and or neurofeedback or other physical interventions to try to help with their ADHD. So of the stimulants that I've seen people report most dramatically as helpful, I've had some people who felt a dramatic improvement with magnesium. I've seen others more commonly who got some help, but it was less dramatic. I've had some who have felt they benefited from fish oil, which I would say the evidence there is more strong for mood and anxiety help, but there is some for ADHD. I have some people who feel calmer with L-theanine added in, and that's been helpful. And this is probably the biggest surprise to me in all my research on these close to 200 videos out here. I've had people over the years who claimed marijuana helped them, and marijuana on the surface, we are usually not considering it a supplement, and on the surface, it seems like a horrible match because we have documented good studies suggesting that regular use of marijuana is associated with less organization of thought, lower motivation, lower energy levels. You would not think that's a good ADHD combination, but I've seen individuals who swear it's been as helpful or more helpful than prescription medications. And there's a very small and probably skewed by the biases of the investigators, but field of research suggesting that a subset of people with ADHD could benefit from marijuana. What else? Oh, when I was thinking of that, there's been some individuals who I've seen who've gotten a tremendous benefit from testosterone, although testosterone and, on its own doesn't seem to have consistent executive function improving effects. So, hello, Wesley again. He said, let's see, a person needs anxiety treatment just to get through a social event of like 4 hours. What would generally be a recommended dose for someone who had never taken benzos before but only needs these once? So again, this is not specific recommendations. I'd say if you've never used, so benzodiazepines for those are drugs like Valium, Xanax, Ativan, so diazepam, lorazepam. Some are marketed for sleep, some are marketed for anxiety. They all tend to help with they all tend to be sedating if you take too much. If you've never experimented with them or taken them, I would actually recommend trying it at least, and your doctor has felt that it's appropriate to use them. So one is, I would say, these are medications that aren't a particularly good match for chronic ongoing anxiety. They are most suited for a very short term, someone who has terror of flying, and whether or not that's more justified these days than usual, we can get into that as a separate issue, or their demolition product is going on next door and all sorts of disruptive noises are going on for the next week. So for a short term, externally driven situation is probably where I would agree with the experts who say that's the most appropriate use for benzodiazepines. So potentially like this discrete social interaction. My recommendation, if you're unfamiliar with the drugs, is to take one same time of day at a different, several days before, just so you can experience what that dose feels like for you, because there's a pretty substantial baseline variation in how sensitive people are to these drugs. There is some cross tolerance with alcohol. So if you are very oblivious to alcohol, you're probably more likely to need a big dose of benzodiazepines. If you're very sensitive and get tipsy with just a small amount of liquor, then you may be sensitive to benzodiazepines and would just want to start at the lower end. The other thing to remember, though, that even a trial run or a test run is only giving some taste or indication, because when you're anxious, the benzodiazepine has something more to work against. So you are likely to feel more sedated, more under the influence of the same dose of the drug in a calm situation than you would in a situation that's hyper-arousing for you. So I can say with Ativan, Ativan is lorazepam. 1 milligram is a standard dose, but for someone, it comes as a half, it comes as a 2. I usually would start low with these drugs. And I will also remind people one of my favorite sayings. is an Ativan in the pocket often works as well as an Ativan in the mouth. So knowing you have a drug that can immediately alleviate, immediately means within a few minutes to several minutes, um, and particularly sublingual under your tongue, Ativan can work pretty quickly. Valium works quickly. Xanax works quickly. How quickly they work is actually a completely separate variable from how long they last with the benzodiazepines. Anyway, knowing that you could take something pretty quickly and get relief creates its own positive feedback loop and is a really effective way of short-circuiting anxiety. So there. So James Alexander asks, is the point of the titration period for Strattera to wait for the side effects to become tolerable while the positive effects are immediate? So this is one area, what I will say differs from virtually every expert I've seen speaking about this or writing about this. There's been some people more recently who align more closely what I say. I'd say the reason people need to go slowly with Strattera is most people can't tolerate it. It is not because we have to wait for positive effects to become present. For years, the experts said this is a drug that works slowly. If you could take an effective dose immediately, I believe you would see immediate benefits because you can with Cymbalta, which has strong norepinephrine reuptake action. You can see that with Wellbutrin, immediate effects for ADHD. Whether there may be additional effects beyond norepinephrine reuptake, there's again some suggestion that this is a drug that works on the NMDA glutamate receptors as well. There may be additional longer-term slow benefits accruing from Strattera, but the whole point of the slow titration is most people can't tolerate the therapeutic dose of Strattera, atomoxetine. So Chad, Austin, and Max may be able to find it while we're talking, asks, can a gene test tell us which ADHD medication will work for a patient? So I do have a video on genetic testing for ADHD, and the simple answer is absolutely no. We do not have any genetic tests which tell which will work. What our gene tests tell is how your body may be likely to process a certain group of medications, how quickly basically your liver is to chew them up and spit them out. Some of the tests also look at other breakdown enzymes, COMT for breaking down catecholamines, or a very few of them look at certain genes for certain receptors. But two things. One is most of the studies are looking at the genes and not the epigenetics. So which allele, which version of a gene you inherit can be important in terms of how quickly you metabolize a drug. So if you inherit sort of one normal variant and one inefficient variant, then you are in general going to have less good processing of the drug. The drug levels will build up higher. But again, whether that doesn't tell you will or won't respond to the drug. It just suggests that you may need a lower dose because it will last longer in your body compared to other people. And two, the genes themselves are different. You may have two versions of an inefficient gene, but if your body has learned, your genes have been regulated so that you are upmodulating and processing a huge amount of inefficient genes, your overall activity in chewing up a drug may be better than a normal person. Or conversely, you may have a very efficient gene for metabolizing a certain drug, but if you are not making much or any of that version, if the gene has been silenced or turned down or off, having the very effective version doesn't do you much good or impact. So epigenetics are one reason these tests are not that helpful at this point in time. I'd say most often clinically, all I've seen is they've confirmed, oh, this person tends to need high doses of lots of medications, or, oh, this person needs a low dose because they're really sensitive to lots of the effects of the medication. So even with antidepressants where there's been more research published, the experts, except those getting, that's a little flippant, paid by the genomics companies, but most of the experts, and there were consensus panels at the American Psychiatric in the last year, say that these tests, even though they've been around for 15 years now, are not at the level of efficiently predicting response to medications. The other part of it is that we've only identified some of the important biochemical points in metabolizing and action of these drugs. So, excuse me. So Beth asks, please help. Initially, I found that Elvance, Vyvanse reduced my appetite, but after about 6 weeks, this changed. It makes me crave sugar every day to the point I basically binge eat. So I should point out that Vyvanse, or lisdexamphetamine, at least in the US, is approved for binge eating as well as for ADHD, binge eating disorder. So that's fairly common. I mean, Adderall, Dexedrine was one of the staples of weight loss medication in the 60s and 70s. And again, it tends to work quickly and effectively at the beginning, and then it tends to lose its effects. But why the change for you in terms of craving sugar and binge eating? I don't have a good explanation, and it's not a particularly common one. When I hear people craving sugar, and particularly still at this time of year, craving sugar and carbohydrates is linked in general to depression. It's more even particularly strongly linked to seasonal depression, seasonal winter depression. And we're just now passing the vernal equinox. So we're getting to the point where usually winter depression is waning. So I don't have a simple answer, and I think most of the approaches, one is it's probably worth experimenting with dose, and usually I go down before I'd go up, and I'd say the behavioral approaches to working with cravings and eatings are what I would emphasize rather than medication answers. So James Alexander, I believe I do have and Max is doing a great job as usual of putting in the chat the specific videos. I do have a video on tolerance. My short version of the talk there is complete discrepancy between ADD experts who say almost everyone might take a few weeks or days to find out the right dose, but then once you find the dose of a stimulant that works for your ADHD, it tends to work indefinitely over years, decades. And the addiction experts would say these are drugs that everyone develops tolerance to, and which is part of why they have some risk for addiction. So I crunched my own numbers, and they were almost exactly like what I thought they were, which was reassuring, but often we have our own biases. So these were people who had been, so this is not just my assumptions. I looked at the actual numbers, people who had been already stable for 1 year on a stimulant dose and looked for the following ensuing year, whether they were still on that dose. A little above 80% were still on the same dose, which is a pretty good rate. And of those who changed dose, more were actually on a lower dose than a higher dose. I think part of that was skewed because I did the study during COVID when there was lots of external contributors to anxiety. And when your own body is flooding you with more norepinephrine, that's a often reasonable reason to tamp down your medication dosage. So most individuals I've worked with have not developed tolerance to stimulants, is the simple answer. So Beth M is following up on the sugar craving is a pretty abrupt departure from her past eating patterns and have lasted for more than 9 months. Yeah, I would, other than sort of the basics of what Overeaters Anonymous or other group, I mean, one is making sure that the food that you have around is healthy, good food, and two, using social connections or pressure if you can, including even if there's a partner or spouse or kids, to say, if you see me going into the ice cream, ask mom, do you really want to be doing that right now? So trying to use social patterns to extend mindfulness and asking yourself, what does it feel? I mean, yes, my body seems to be craving or telling me I should eat it, but do I really need to listen to that part of my body? Is it giving me good advice? That's general frameworks. I don't know if that's helpful at all. So, and I'm at an hour now, but I'll try to answer the questions that are here. So James, and I'll give quicker answers than I usually do. James Alexander is asking if patients tended to see much benefit when it comes to inattentiveness and lack of focus from the alpha agonist. So I'd say yes, I have. Again, I have people on guanfacine who didn't feel it did anything. That's not an insignificant proportion. But of those who felt that it helped, it didn't just damp down hyperactivity or impulsiveness. Very clearly, some of them feel more focused, more able to attend to what's important to them in their lives. So Max has some links to some of the videos we've touched on. Back to Wesley. He's mentioning the sugar cravings. And he's suggesting eating complex carbohydrates and fiber. Well, I'm throwing in the complex carbohydrates rather than the things with a high glycemic index that break down quickly. That fiber seems to slow digestion, and it helped him. So thanks for bearing with me. Hopefully our connection will be better next week. Welcome to all those who are joining us from having seen me on the Huberman podcast, and I will be back next week. Stay healthy, stay happy. Bye.